Welcome, dear audience, to our another session of International Educational Ophthalmology series. Today, our topic of discussion is about the effect of bariatric surgery and GLP-1 on human eyes. More and more patients are undergoing these surgeries to get benefit in weight reduction and their blood glucose level control. But it has got certain effects which needs to be considered before undergoing these surgeries and even after that. In order to discuss the effects of weight loss, bariatric surgeries, and GLP-1 on human eyes, we have requested Dr. Humair Khan from Texas, USA, to guide us and educate us on this topic. Dr. Humair did his graduation in medicine from Baylor Medical College. He did his residency from Texas Tech University Health Sciences Center. And later on, he did his cornea fellowship from the University of Southern California. He has also served as an assistant professor for 8 years in Texas. Currently, he is the chief executive officer of the Bright Eye Institute. He has extensive experience in the management of cornea, refractive surgery, ocular surface diseases. And so we are thankful to him that he has given us time to educate our audience on this new trend which is coming for surgeries, of course, which is very beneficial for our patients. They undergo these surgeries and these treatments, but what are their effects on human eyes? So today he will educate us. So without further delay, I will request him to please present his talk.
Thank you so much for having me today.
Yes.
Okay, so yes, our topic today is ocular metamorphosis, the ophthalmic effects of bariatric surgery and GLP-1 receptor agonists. So as we all know, the obesity epidemic is not affecting just one particular country, but it is a global epidemic. Well, we've seen a rise in the BMI over time, and this has had deleterious effects on the human body in many ways. So now we have multiple options that we can use to combat this. We have surgical interventions, and now we have medical interventions that are also quite effective. So ophthalmology must pay attention to this because these medications are relatively new and they do have many effects on the entire body. When we look at the GI anatomy and the obtaining of the actual nutrients for the eye, we have to look throughout the gut to see what is contributing and where it's happening. So when you look at the stomach itself, you can see that there are healthy cells within the stomach that make an intrinsic factor, which binds with vitamin B12. Then the vitamin B12 is able to enter the bloodstream later on. But without the intrinsic factor, you will not get absorption of the B12. The other area that we need to look at is within the small intestine. So the duodenum is actually quite important for fat-soluble vitamin absorption. When you look at vitamins A, D, E, and K, if you don't have a healthy duodenum, you won't get absorption of these critical vitamins. And then the ileum is important because this is where the vitamin B12 intrinsic factor complex we talked about earlier is actually absorbed. So this is also a very important area when regards to the ocular micronutrients. So when we look at bariatric modalities, we can see something which is called a sleeve gastrectomy. So when you look at the procedure itself, it's essentially removing a large volume of the stomach. The good thing with this is that the entire pathway remains preserved, meaning you still have esophagus to stomach to duodenum, jejunum, ileum. You're not bypassing anything. The next bariatric modality is the Roux-en-Y gastric bypass. When you look at this, you are decreasing the volume of the stomach, right? You're creating a gastric pouch, but when you look at it, you're creating a new pathway where the stomach is no longer going through the duodenum, but now it's emptying its contents into the jejunum. And so this is going to have inevitably an outcome that's going to impact the eyes as well as the rest of the body. So when we look at timelines of depletion, so when you are bypassing things, or if you're not able to physically eat enough to get the nutrients that you need, you can deplete the essential vitamins that you may need for your body. So water-soluble vitamins don't have much of a reserve, usually months. So the B1 and B12, these water-soluble vitamins can be depleted within months. Now, when you look at fat-soluble vitamins, it's important to note that it does take years for you to deplete your reserves. So you may notice that initially after bariatric surgery, everything is going just fine. And so the primary care and bariatric surgeon may actually decrease your vigilance over time. And that's really when the vitamin deficiencies can become apparent. So as in this photo here, where you can see some patchy RPE atrophy of the fundus. So what are some of the positives of using bariatric surgery for obese patients? So when we talk about ophthalmology, we know that idiopathic intracranial hypertension, which is elevated intracranial pressure, is directly affected by obesity. In many cases, when we treat the obesity, we're able to get a drastic reduction in the intracranial pressure, which is actually therapeutic for the IIH itself. And as we know, this will then preserve the optic nerve and keep it from getting damaged over time, and therefore save a patient's vision. The other great thing about doing bariatric surgery is you will see an improved retinal perfusion, and it usually happens within months. So this will be actually before you've even seen massive weight loss, you'll already start noticing increased retinal perfusion. We know that when we have a loss of weight, it's going to make our arteries healthier. When we look at the OCT angiogram data, we'll actually see this translate into increased macular vascular density. So it is really quite impressive, the positive impacts that it can also have for the eye. Now, with regards to some of the deficiencies we spoke about earlier, when you look at the Roux-en-Y gastric bypass procedure, we see that we bypass the duodenum, which is very important for vitamin A absorption. So you can see vitamin A deficiency manifest in different ways, both in the front of the eye and the ocular surface here. And you'll see loss of conjunctival goblet cells. When you lose the goblet cells, you're losing that important mucin layer that's necessary to adhere the tears to the surface of the eye, which leads to one of the reasons why the eye gets so dry. Because of the significant dryness of the surface, the eye compensates by performing a squamous metaplasia and conjunctival xerosis, as you can see on the image on the right, where you don't have that beautiful reflection of the tear film. It's a very, very dry and transformed surface. The other thing that you'll see is Beteau spots, as you can see on the conjunctiva there, which is basically foamy areas of the cells with bacteria and keratin. So we know that keratin is used for waterproofing of an eye, and we don't want to waterproof an eye. Normally we use keratin in our skin to waterproof the skin, but areas like the mucosa of the eye are meant to be moist and wet. So when we have keratinization, that's actually a very bad sign. It means that the cells have been so dehydrated that now they're undergoing these changes, which is changing the complete architecture of the eye. So vitamin A deficiency on the anterior segment can continue to wreak havoc. If it is unchecked, you will have some vision-threatening corneal ulcers. And the reason this happens is you're getting a sterile corneal melt. The increased inflammation and the persistent epithelial defects lead to activation of matrix metalloproteinases, which can have significant impacts and can be a surgical emergency. In these cases, I found that management is very helpful to have high doses of vitamin C, doxycycline as an anti-MMP, but surgically, it is very helpful to use multi-layered amniotic membranes. I specifically will use about 6 layers of amniotic membrane with fibrin glue in between each of those layers, and then purse string sutures to secure it to allow the eye to heal. A tarsorrhaphy is also very helpful in these situations. So vitamin A deficiency will also affect the posterior segment. But when we look at these images, you can see the fundus photos up top shows areas of retinal pigment epithelial atrophy and damage. When you look at the actual autofluorescence, you will see areas of hypoautofluorescence as evidenced by the dark areas in the macula. And when we look at the OCT of the macula, we'll see that the optical coherence tomography shows that there is atrophy of the RPE in some of the outer cells. You get a rhodopsin deficiency because we know vitamin A is important for that. This leads to night blindness as well. So not only can you have a significant decrease in the central visual acuity, but the patients will also regard night blindness as being decreased. And this would be actually something that's quite important for our colleagues to discuss with their patients. So a PCP or a bariatric surgeon who has a patient who has had a surgery in the past should continue at their yearly screenings to be asked about night blindness. And so the retinopathy that occurs can be quite significant. Now, this leads us to our next area of the eye that can be affected, which is the optic nerve. Optic neuropathies are often seen when we have deficiencies in vitamins. Classically, we learn about vitamin B12 deficiency or folate deficiency as affecting the nerves negatively. But you must be vigilant for other micronutrients in these patients who are not able to consume enough nutrients. Copper deficiency is actually quite important. And I had a patient who presented with acute loss of vision and was coming to me for a consultation. The eye exam was all normal, except when I looked at the nerve, I saw that the patient had some paleness, and the pallor of the nerve was located within the temporal aspect, which we know is an atypical location for pallor. Whenever we see paleness of the nerve in a temporal location, we must always think about toxic and metabolic outcomes. So when I asked the patient further, she mentioned to me that she had had a gastric procedure in the past to lose weight and that she was also not eating very much. So my suspicion was already very high. So I had her go to the ER and had them do testing for her with the recommendation that she be admitted for supplementation. These patients will present with painless bilateral progressive vision loss. You have to be very diligent and do an amazing exam for them. Otherwise, you may miss that early temporal atrophy. The one other thing that I wanted to mention is when somebody has supplementation being done for a vitamin deficiency, if the digestive tract itself is not intact, oral supplementation is useless. Unfortunately, the patient that I had referred to the emergency room at a nearby hospital, they admitted her and did the workup, but then they discharged her without giving her IM supplementation or IV supplementation. So unfortunately, her PCP put her on oral supplementation, and I reached out to the PCP directly and recommended that they do either IM or IV supplementation. Unfortunately, they did not follow the recommendation, and this patient ended up with irreversible blindness. So it is important for us to discuss with our colleagues about the importance of why we need to help fix the deficiency and the importance of the mechanism by which we are also repleting it so that we don't miss something like this, which can be quite tragic. So when we look at established disease, we know that bariatric surgery can have an impact on age-related macular degeneration. Fat itself is acting as its own endocrine organ, which releases many pro-inflammatory cytokines, in addition to its aromatase activity, which converts testosterone into estrogen. We also know that fat can create pro-inflammatory cytokines like interleukin-6 or tumor necrosis factor alpha, which the inflammation from that can actually lead to more damage of the retinal pigment epithelium. So one of the good benefits of bariatric surgery and weight loss is it is actually protective against patients from developing macular degeneration. When we look at the effects of low-fat soluble pigment absorption, it is a double-edged sword because you can get loss of macular pigments like the lutein and zeaxanthin. Bariatric surgery and macular degeneration, as I mentioned earlier, obesity is a driver of it, and the adipose tissue creates oxidative stress, which directly damages the RPE. When you look at the TriNet-X database study, this was a massive retrospective cohort study. It had 42,000 morbidly obese patients who underwent successful bariatric surgery. So when we look at the control group, it was morbidly obese patients who were being managed medically. The outcome was very, very remarkable. So we saw the surgical cohort actually had a 37% reduced future risk of getting a diagnosis of macular degeneration compared to patients who didn't have surgery. That's a very high percentage difference. And the massive reduction in the adipose tissue effectively decreased that inflammatory drive we talked about earlier. When you look at a YG bariatric procedure, we know this has the highest risk due to what we talked about earlier in the anatomy of the bypass. You have to recognize the timeline and must keep vigilance over time so you can avoid these tremendous potential side effects of blindness. Oral supplementation is often insufficient when you have bypass. So next, I would like to shift over to the next portion of our talk, which is looking at incretins. So we know that incretins are basically a group of metabolic hormones that decreases blood glucose levels. So our body has many different types of incretins. Now, when we look specifically at GLP-1s, right, which is the glucagon-like peptide ones, like Ozempic and Wegovy, semaglutide, that have been helping so many of our patients successfully lose weight, they have many, many varied effects all over the body. So when you look at the brain, if you look at animal models, you will see that it actually leads to neuroprotection, appetite suppression due to the way it signals our satiety centers. When we look at the heart, we see that we get cardioprotection and increased cardiac output. In the stomach, of course, we know there's decreased gastric emptying, which leads to a decreased appetite and is one of the main drivers of the weight loss. The other very interesting thing about GLP-1s and why they are so beneficial compared to some of the other medications we've had to treat diabetes in the past is they increase the beta cell proliferation while at the same time decreasing beta cell apoptosis. We know that insulin is made in the beta cells, so we're getting a net effect that is going to increase our beta cells in our pancreas. This will lead to increased insulin synthesis. The other amazing thing about GLP-1s is not only do you have more insulin, but you actually have a greater insulin sensitivity. The amazing thing about a GLP-1 is that it will act by increasing insulin secretion when blood glucose levels are higher. The reason this is important is when you look at traditional ways of decreasing blood sugars, such as administering insulin or metformin or other older medications, those can have hypoglycemia as a very common side effect. Because GLP-1s only increase insulin in the presence of increased glucose, you don't have as much hypoglycemia with this group of medications. So the glucose-dependent insulin release is quite important and is a novel way to treat diabetes and obesity. You get delayed gastric emptying, which is one of the main drivers of weight loss, and the CNS satiety I talked about. So when we look at the GLP-1 roster, we know about Ozempic and Wegovy. Semaglutide is the generic. Tirzepatide is our Mounjaro and Zepbound. And then we have some newer players like liraglutide and dulaglutide. Whether they're branded or they're generic, and we're using these for type 2 diabetes or weight loss, we should know that the mechanism and the ophthalmic risks remain the same. We may have more data on some of the older medications, but that doesn't mean that the newer ones are safer. It just means we haven't gotten enough data to know exactly the negative effects yet. So when we look at the positives for GLP-1s, we get long-term stabilization. So when you look at macular degeneration, when you look at non-exudative macular degeneration, or even the formation of macular degeneration over time, the GLP-1s are actually protective. You also get a massive reduction in lifetime diabetic retinopathy progression. And there's also a direct retinal neuroprotection effect that we've seen in animal models. So when we talk about GLP-1s and macular degeneration, we need to know that this is actually one of the most exciting frontiers in research currently. The benefits of the GLP-1 extend far beyond just the mere weight loss. And the reason for this is actually quite amazing. So these GLP-1 receptors are located directly in the retina. So they're actually being expressed right in the retina. So when we activate this by taking a medication like Ozempic, our GLP-1 retina receptors are actually being directly impacted. And this leads to a neuroprotective and anti-inflammatory effects for the RPE and the photoreceptors. So look at the non-diabetic obesity cohort in JAMA Ophthalmology. This was a groundbreaking study of over 91,000 patients that had obesity. They did not even have diabetes, but they had obesity. And we compared them to patients that were just using normal weight loss drugs that we had in the past versus the newer GLP-1s. The risk reduction for developing dry, non-exudative macular degeneration was massive. At 5 years, there was an 83.5% risk reduction of developing AMD. And when you follow these patients over time, the most amazing thing was that over time, that difference actually became greater and greater. So it actually became more and more productive for macular degeneration. So when you think about it this way, it may very be possible that when you have a patient with a strong history of macular degeneration who has not yet developed it, if it's possible to incorporate a GLP-1 into their regimen, it may actually be quite protective for them. Now, looking at the Cleveland Clinic study, the older adult cohort, patients over age 60 took GLP-1s versus other metformins, insulins, or statins. The GLP-1 reduced the hazard of non-exudative dry macular degeneration by roughly 30%. And this perceptive effect became statistically significant after 3 years of continuous use. So this is looking at now GLP-1s and exudative or wet macular degeneration. We know with wet macular degeneration that there's a damage to the choriocapillaris and to the barrier between the macula and the blood supply, which leads to fluid accumulation. As you can see in this OCT macula on the right with the dark cystic fluid pockets in this patient with wet macular degeneration. On the left, you can see the patient has some edema and hemorrhage in these same areas. Interestingly enough, when we look at GLP-1s, this is where they can actually have a negative effect. So in older diabetic patients that are on GLP-1s, the rapid systemic metabolic shifts trigger a transient increase in the risk of progressing to neovascular wet macular degeneration. Part of this can be attributed to the changes in the osmolarity of the patient. When you have blood sugar, we know the retina gets used to finding a way to function with high blood sugar in these patients with ischemia. When you all of a sudden rapidly decrease their A1C, let's say by 3 points in a matter of 1 to 2 months, you're having a massive shift in the osmotic gradient. And this can lead to damage to the eye. When you get this damage, this will lead to VEGF being produced, and it has these effects in wet macular degeneration. Now, the other paradox, we know that diabetic retinopathy progression is lifetime much less in patients on GLP-1s than those who are not. However, if you look at patients with diabetic retinopathy that's already pre-existing, we can see an acute worsening of the diabetic retinopathy. So this is due to normal glycemic re-entry, right? Where we talked about those shifts in osmotic pressures, and that leads to shifting of fluids and an increased demand for nutrients, which is then compensated for by the body by releasing VEGF. And that can have these effects of fronds of neovascularization, as you can see on this patient's macula for this right eye. So the rapid hemoglobin A1C drop leads to that transient VEGF spike, which I was just mentioning. So the SUSTAIN 6 trial looked at semaglutide versus placebo, and we looked at retinopathy complications with this. The hazard ratio was 1.76. Patients on semaglutide had a 76% higher rate of vitreous hemorrhage, blindness, or needing pan-retinal photocoagulation or intravitreal injections. And the reason for this is due to the increased VEGF that occurs when you have a very rapid loss in weight and a very rapid change in A1C. So the NAION controversy. So non-arteritic anterior ischemic optic neuropathy is a cause of blindness. And this is something that we as ophthalmologists diagnose and treat quite often. However, patients that are under the care of a bariatric surgeon or their internist or endocrinologist may not have that same level of nuance with regards to diagnosis and management of NAION. Some of these providers may not really even be sure why NAION happens. You look at the JAMA ophthalmology study from July 2024, this is one of the studies that started to get red flags going with regards to GLP-1s. They looked at semaglutide versus non-GLP-1 patients, and it was a retrospective matched cohort. So we know this was associations and not actual causation. However, when you look at the Mass Eye and Ear study over 36 months, they found that there was an association between semaglutide and NAION. So the type 2 diabetes cohort had a hazard ratio of 4.28, and the obesity cohort was 7.64. So in the obesity cohort, the patients on semaglutide were over 7 times more likely to develop an irreversible optic neuropathy. And this was an observational study, not causation, but the signal was incredibly strong. So what are some of the proposed mechanisms of NAION? Well, again, it goes back to rapid shifting. When you have rapid changes in osmolarity, you will see changes in the blood volume, blood pressures, as well as shifting in and out of different compartments of the body. Because the eye has a very tight blood-brain barrier, we know that the eye is generally shielded from different things from getting in and out of the eye. But when you have rapid flux of glucose, the eye is not going to be protected by that because glucose is vital. Nocturnal hypotension is proposed to be a possible mechanism, which it is also for just NAION in general. A sympathetic nervous system activation, which could change the tone of the vessels and thereby change how the vessel is able to get perfused. The optic nerve head hypoperfusion can then put them at risk. Now, okay. So this optic nerve head hypoperfusion can lead to damage to the nerve. So the disc at risk is the most important thing. When we see a patient who has a very crowded nerve, you can't even really appreciate the cup within this nerve. These patients are already at high risk for NAION. I recently had a patient who was in her early 40s who was maybe overweight when I saw her and had started taking a GLP-1 6 months prior to her seeing me. She had no other health conditions, was not a smoker, and did not have hyperlipidemia or hypertension. Unfortunately, she came to see me with loss of vision, and she was noted to have actually NAION bilaterally in both eyes. When I saw that a patient that was otherwise in her early 40s and young, presenting with NAIONs, this was quite a red flag for me. And that's when I started talking to my colleagues and trying to educate them more about the negative effects of GLP-1s. A small crowded cup to disc ratio, in my opinion, should be a relative contraindication to GLP-1s. We know for some patients, though, they have such a tremendous obesity problem that the risk to their life and limb may actually far exceed their risk to their vision. So in these situations, we do need to collaborate with the internists and the endocrinologists and the bariatric surgeons to have a very important discussion about the benefits and risks so that the patient is well informed. So this is, of course, we know the risk factor for NAION. GLP-1 summary. So you get an early worsening of diabetic retinopathy and wet macular degeneration, which is driven by the speed of A1C reduction. NAION risk requires baseline screening. If a cup to disc ratio is not apparent, meaning the patient has a crowded disc, we must have a very serious conversation with the providers. The systemic benefits are very great. Our job isn't to cause fear or panic. We simply need to do what's going to be safest for our patients. We know these medications are not going anywhere, and it's a good thing because they are helping our patients significantly, but we also have to have the role of physician and be protective of our patients. So multidisciplinary care coordination is very important, as I mentioned earlier. You want to grade diabetic retinopathy and use that to also guide your follow-up. If you want to err on the side of being conservative, I think that would be smart. When somebody starts a GLP-1, maybe see them back in 1 or 2 or 3 or 4 months rather than bringing them back in 6 to 9 months. You want to evaluate the optic nerve, make sure it's not crowded, and assess the surface. So as I mentioned, we do want to talk about making sure that the A1C is not reduced too quickly. The A1C didn't rise within a month, and it shouldn't also be decreased within a month. Just like it took years and years for the A1C to reach this point, it's okay if instead of losing the massive weight in 2 months, the patient loses the weight over the course of 6 months. It'll actually be safer for them that way. So for patients that are high risk with moderate NPDR or more, seeing them back in about 3 months at least would be a good course of action. If they're low risk, I would probably err on the side of maybe 4 to 6 months actually. If they have established diabetic retinopathy and are starting a GLP-1, bring them back so that you can make sure that they have not had a massive VEGF surge, which is usually when you'll see it clinically actually manifest, would be about 3 months after starting. Patient education is important. We have to discuss the paradox with them that it is protective for them in the long term, but in the short term, it could potentially cause worsening. And let them know that if they have new floaters, flashes, sudden vision loss, or field defects, they should call you at the office right away. So the future landscape, we know dual and triple agonists are here and they're coming. Endoscopic bariatric procedures are around, they're not going anywhere, and the medications are only getting stronger, right? So we need to be aware as ophthalmologists, and we also need to educate our colleagues about this important matter. So let's go over a couple of case studies. So there's a 45-year-old female, 5 years post RYGB. She comes in with burning, foreign body sensation, and nyctalopia for 6 months. Conjunctival xerosis is apparent on the exam, as well as Bateau spots. And she's been using preservative-free tears for 10 times per day without relief. This actually was a patient that presented to me when I was at the University of Texas. The patient was seen by another optometrist actually for about 4 months prior to them referring the patient to me. Unfortunately, they had misdiagnosed the patient with severe dry eye and had been in vain trying to treat dry eye. By the time the patient got to me, his vision had decreased to a legal blindness level, and he was previously noted to just 6 months before to be 20/20 in both eyes. And so we know this can have a big impact. And by making the diagnosis, I was able to get the patient admitted, and they were able to use the WHO criteria for vitamin A replenishment successfully in the hospital. And the good news was the patient actually was seeing 20/20 in both eyes when I saw him again 2 months later. So the trap, of course, optometrists can have misdiagnoses of things since they don't have the same training as a physician does. Severe vitamin deficiency is something we have to look out for. Again, we know the timeline, it takes years, right? Because the fat soluble vitamins take years before they're depleted. So continuing on, case 2, a 58-year-old male with type 2 diabetes for 15 years, baseline mild non-proliferative diabetic retinopathy in both eyes and an A1C of. So he had an intervention of semaglutide, and a 4-month follow-up had sudden floaters, and the A1C had decreased significantly, and the exam showed high-risk PDR with fresh vitreous hemorrhage. So the management, do we stop the GLP-1s at this point? No. We do need to intervene, though. We need to do PRP and or VEGF. So you keep the GLP-1 going and treat the diabetic retinopathy at this point. So then there was a patient who had a Roux-en-Y procedure. She had, fatigue, and she had oral supplementation, which unfortunately led to a decompensation of the ocular surface. The next case, a 55-year-old male with longstanding diabetes and NPDR. His A1C dropped significantly, but he had a new vitreous hemorrhage and high-risk PDR. So again, this basically is just talking about the same thing, which is acute worsening of diabetic retinopathy. You don't discontinue the GLP-1. We know that at this point, the A1C is already lower. It doesn't make sense to stop it. We just treat the proliferative diabetic retinopathy. Optic neuropathy, as we talked about, is very important. In addition to vitamin B12 and folate, we need to look for copper. Pre-therapy screening is very important. We want to make sure that we are checking for a cup to disc ratio that is like not apparent, meaning a crowded disc. And systemic care coordination is vital, especially since these are newer medications and we are the experts, we are the ophthalmologists. So we have to be the ones that are in control of the patients and their safety. So bariatric surgery can lead to malabsorption. GLP-1s cause rapid shifts, which can worsen diabetic retinopathy acutely and may also be associated with an NAION. Screen before they start. Thank you so much for your attention. It's been an honor and a pleasure to present to you today. So we'll take questions now if you'd like.
Dr. Homer, one thing is, as you mentioned about optic neuropathies in these patients who are undergoing bariatric surgeries or GLP-1 using. Are these changes in optic neuropathies are because of these metabolic changes or fluid changes which are happening over there? Or we also know there are some receptors of GLP-1 on the optic nerves. What do you think, which is most main reason for these effects?
Yeah, so, I would say based on our knowledge of NAION, we know that patients that have hypoperfusion overnight generally are the ones that have an increased risk of it. And that's usually more so due to ischemia. And so the current thought is that although there are GLP-1 receptors located within the eye itself, we know that the patients themselves, or at least in animal models, we've seen a neuroprotective effect. So if anything, we would say the actual GLP-1 specific portion of it may actually be helping things, although we can't prove any of that yet definitively. The thought right now is that it is most likely due to the rapid shifts that we're seeing in the blood glucose, the A1Cs, and possibly something that's happening in the sympathetic tone that's changing the blood supply that's predisposing these patients to the NAION. We know patients with NAION with a crowded disc actually have less blood vessels supplying the nerve. So that's why it's nice to have a larger one, because then you have multiple vessels just from a statistical standpoint. But at this point, yes, we're thinking it's most likely due to these other factors and not actually due to the specific direct effect of the GLP-1 receptors. But that's a great question.
Dr. Homer, I know you are an anterior segment and refractive surgeon, but still I want to know, you have any idea or any studies about the effect of GLP-1s and bariatric surgery on the glaucoma control or something affecting their management?
I'm not going to cite a direct study on that, but what I will say is that anything that improves vascular perfusion pressure for our patients should actually have a benefit outcome in the long term. Although that's a great question that you bring up, because if somebody has severe open-angle glaucoma, they don't have many RNFL fibers that are left. And we know patients that we do surgery for, we're very cautious with to keep them from getting an IOP spike. If they get an intraocular pressure that is acutely rising very high, there have been reports of patients going completely blind just from that little bit of extra damage to the nerve. So I think this is a fantastic question that you bring up. And as a community, this would probably be another patient subset where we may say, hey, we really want you as the internist or as the weight loss management expert to titrate slowly for these patients who don't have that much left of their nerve. Because if these shifts happen and they cause damage to the remaining part of the nerve, that could be very, very drastic and a very, very devastating outcome. So that's actually a fantastic question. I'm glad these are the reasons why we do these kinds of meetings, so that we can talk to each other and actually come up with even new screening criteria. So I'll actually take that and actually apply it to my screening criteria for severe glaucoma patients, because we would rather be conservative than to trust that this is going to work and no problems are going to happen. But I do think it'll be similar to macular degeneration and diabetic retinopathy when you look at it as a whole over time. I think this will probably be something that could potentially be protective If you increase perfusion pressure to the eye, regardless of if it's with lowering intraocular pressure or by increasing the systemic blood pressure that's coming to the nerve, you should increase the health of the nerve and the livelihood of the nerve in the long term. So I think that's a fantastic question, and that's something that we need to have further studies and research in.
Well, Dr. Humair, you have explained in great detail all these aspects which are related to these treatment modalities. And I hope this will be very beneficial for our audience, especially about dry eyes and retinopathies. And I appreciate that you have given us time to educate our audience, and it will be very beneficial for them. And I know you're very busy with your schedule, but still, when I invited, you decided to and accepted the invitation. So I want to thank you on the behalf of all of our audience, and we are looking forward to more sessions in future also. Thank you, Dr. Humair.
Thank you so much. It's been an honor and a pleasure. I appreciate the invitation, and I look forward to collaborating with you again.